ज्वाइन. अभी वो दूसरा खत्म किया, मैंने कहा चलो अभी ज्वाइन करते हैं. चलो. Dr. Khaiwal has joined. I'll just see.
Sorry, I got disconnected.
No, I said Dr. Khaiwal has joined or not. I don't know.
I have to
I can't
see.
Yeah, दिख नहीं रहे ना.
नहीं दिख रहा है.
Anyway, we can start and we can talk. I call him.
Kaushik is here. Kaushik is here.
Yes, ma'am, I am here. Although I am traveling, I am here.
And who will conduct? Ripu will be here.
Dr. Ripu is here.
Yeah.
Okay.
I think he will join within
Who?
few
Khaiwal?
minutes.
Khaiwal or Ripu?
Ripu.
Ripu will join. Okay. So we can wait for some more time.
I think we should start. Yeah, we can start. By the time, he joins, we'll call Dr. Khaiwal also, right?
Okay, 55
right.
already, 56
Yeah.
joined. 56
Yeah.
joined.
Dr. Rajiv Dasgupta has joined?
Yes, he is
Yes.
here.
Yes, I am here.
Yeah, he was
Okay,
amongst the first ones to join.
Okay, it's a request from the IPHA headquarters. I'm just seeing the chat that rename your Zoom profile name, because that name will get the Google registration name will get the e-certificate. So if there is any other name, so that will not be considered for the certification. So participant, please rename your Zoom profile. Some of them are not in some other name.
Yeah.
Kaushik,
So
you can
shall we
start.
start or wait for Dr. Khaiwal?
I think we start. I will just talk.
Just
Good
let me
ma'am.
connect
Good
with him.
afternoon, Dr. Mitra, Dr. Bose. I
Good
am
afternoon.
there. I just reached from NCDC to here.
Okay,
Chalo,
okay,
acha
sir.
hai.
Okay. Thank you.
Thank you. Namaskar, ma'am.
Namaskar.
Namaskar.
Actually, there is a national review going on of National Program on Climate Change and Human Health, and it was on the last minute, so that's why we have to be here. And I will be joining through my
Okay,
laptop
so,
in few minutes. Thank you.
Okay, sure.
So shall we start?
Yeah,
Yes.
you can start then. Dr. Khaiwal will be the first speaker, no?
No,
So
no.
Okay.
you can start.
Dr. Rajiv is the first speaker.
Okay.
No, I'll come in second.
Okay, you want to come in second? Okay. Then we have to wait.
No, I thought.
So
I
we
thought
can
that's
start.
No,
We
no.
can
That's how
start
it's
that introduction.
Yeah, you can
Oh,
start
no,
with the
that's-
introduction at least. Yeah.
Yeah. Ripu, Kaushik, please.
Yes. So good evening, everybody. Once again, I welcome you all to this platform for observing World Environment Day, which was held on 5th of June. To celebrate this day, we have taken this 8th of June today, and we have two eminent speakers with us, Dr. Rajiv Dasgupta and Dr. Ravindra Khaiwal, and along with them, on behalf of IPHA headquarters, we have our President, ma'am, Dr. Shanghomitra Ghosh. We have our Chairperson, Chairperson of Indian Academy of Public Health, Professor Dr. Sunila Garg. We have our Joint Secretary East, Dr. Ibhu Basu with us.
Hello.
Hello. Yes, you are
Ribu.
here.
Yeah.
Hello, everyone.
Hello.
Yes, Ribu.
Yes, we can hear you.
We can hear you. Yeah.
So, as we are just starting, we know that climate change has a range of direct impacts on human health, including injuries and illness from extreme weather events. The capacity of health system is also rendered vulnerable in terms of infrastructure and services. Health systems therefore need significant strengthening to be responsive to these challenges. So making health systems climate resilient entails a wide range of strengthening of building blocks of health systems to significantly enhance the overall functioning of health system. To speak on this topic, we have Professor Dr. Rajiv Dasgupta with us. He needs no introduction. He has served over a decade with the Epidemiology Division of the Municipal Corporation of Delhi and is currently the Professor of Center of Social Medicine and Community Health at JNU, New Delhi. And he was Fulbright Senior Research Fellow and Visiting Associate Professor at Johns Hopkins Bloomberg School of Public Health and Visiting Professor, University of Technology, Sydney. And he is presently the editor of Indian Journal of Public Health. And along with Dr. Rajiv Dasgupta, we have Dr. Ravindra Khaiwal sir with us. And he will be joining within a few minutes. And Dr. Khaiwal also needs no introduction. He is a professor of environmental health and has an experience of 25 years of research in the field of environment and public health. And he is at present in PGIMER. And he has more than 150 articles having a H index of 54 with over 13,000 citations. And he has 21 projects and 15 as the principal investigator. He has received the Fellow of Higher Education Academy UK, receiver of P.N. Raju Oration Award by ICMR and other awards as well. So I would like to request Professor Dr. Sunila Garg ma'am to say a few words.
Thank you, Dr. Kaushik. I think this is the third masterclass which we are having in less than, I'll say 1.5 months. So first, we started with the class on research methodology. Then we spoke on, smokeless tobacco on World No Tobacco Day. And now today we are talking on World Environmental Health. Particularly we are going to focus on two issues. One is we are talking about the health systems, which is very, very important and the need of the hour, which is, it calls for, leadership, governance, capacity building, financing also, that is very important, and plus health management information system. So that is where, it is very important to listen to this part of health system strengthening, from the perspective of environmental health. And also when we were talking about Dr. Ravindra Khaiwal, particularly in last 3 years, I will say that during COVID times, he brought out lot many, I'll say publications, comics and all that, which were of, use to common man in terms of, particularly children, when he educated them with regard to, in the form of comics and all that. So today's topic is very, very important. And I will request Dr. Sanghmitra to say a few words also. Dr. Sanghmitra, please.
Thank you, ma'am. Welcome to the World Environment Day observation by IPHA headquarters. This is third masterclass of this year. Actually, we used to have these masterclasses earlier before the conference also. And this time, 2023, the theme was Beat Plastic Pollution. This plastic pollution is doing havoc on our health. It's especially we are concerned about the microplastic also. And it is this day actually we wanted to observe on 5th, but we have to postpone to the 8th because of the busy schedule of our speakers also. And this day is actually the reminder that people's action on plastic pollution matters. and the steps governments and businesses are taking to tackle plastic pollution are the consequences of this action. So there are highlights also. It will be discussed by Dr. Ravindra Khaiwal and Dr. Rajiv Dashgupta. Both are very eminent speaker, and I'll not take much time from the speech. So they need no introduction. Already Dr. Kaushik Mitra, Secretary General, has introduced. So please enjoy the speech. And if you have anything, so just write down on the chat box. Our all the moderator and our secretary, they will confirm the question answers, and this will be recorded. So, and this will be also given in the YouTube or IPH YouTube channel. So you can observe, you can take the recording from there also. So thank you very much. Thank you to the speaker. Thank you, ma'am, Dr. Sunila Garg, ma'am, because she's the brain behind it, and she's our inspiration for this. So thank you so much, ma'am. So please carry on.
Thank you.
I think Ribhu will take over.
Yeah.
Dr. Ribhu.
No, I am there. Okay.
Okay.
I can put the video on.
You can call the speaker and you can start.
Yes. So I now kindly request Dr. Rajiv Dashgupta please to start his delivery.
No, Rajiv will be second and Dr. Khaiwal will be the first. Rajiv has spoken. Dr. Khaiwal has come?
Dr. Khaiwal is not yet here.
Not yet here. So Rajiv, there is
Hello,
no...
ma'am. Do you want me to go first?
Yeah.
Yeah, we want you to go first. Yeah.
Okay, ma'am. Just give me 1 minute. I am sharing my PPT from my laptop.
Sure.
Okay.
I have
sure.
logged in there.
Okay.
Oh. Actually, I got disconnected. And
Yeah, we can see your screen.
Okay.
Good evening, everyone. It's a pleasure to be on this platform of Indian Association for Public Health, and I'm really grateful to Dr. Sanghmitra Ghosh, Dr. Sunila Garg, and Dr. Kaushik Mitra, and all of you for joining for today's event. If we remember for today is World Ocean Day, and as Dr. Mitra highlighted and Dr. Ghosh highlighted, it was the theme of plastic pollution of this year. What does mean plastic pollution means? Basically, this is an emerging threat to our environment and our health. If you look at our life has become the plastic, and that is why to highlight the significance of plastic pollution, the theme of this year was Beat the Plastic Pollution. And the request was that how we can minimize the single-use plastic in our daily life, so that as a part of this lifestyle for environment movement, or you can say as our contribution to the environment, where we become a part through behavior change modification to support the activities of clean and green environment and sustainability, we need to act and work something. So that's why we celebrated this for Environment Day. But I wish to highlight another important topic on this occasion also is air pollution. I hope you are aware that globally, we can link more than 10 lakh deaths to the air pollution. Either it's indoor air pollution or outdoor air pollution. When we talk about air pollution, basically, we can divide it into, if you look at on this slide, basically, how the clean environment is there. And this is a rural site where we monitor our air pollution. And at the right hand side, you will see that there is a continuous air quality monitoring station, which we make use because we try to monitor the real-time air quality concentration. So when I say real time, it is a near real-time air quality station. The reason we need to work upon is we have a Indo-Gangetic plain, which is known for its productivity, means in terms of crop yield. But at the same time, it is highly populated area. At the same time, you know, it become like a gas chamber during the October-November period and also affecting the air quality in the region. So starting from Kashmir region to then Himachal, then Haryana, Punjab, if we look at where this pollution and it's towards Kolkata basically. So that is the, you can say, emission side to, then we can say that pollution settling down towards the Bay of Bengal. Now, this is the situation which I was talking. So you can see that during that period, the air pollution episode becomes so common that we see sometimes severe air quality. And if you remember, there is a AQI based on PM 2.5 and AQI, a list is released today. And out of the world top polluted cities, most of these cities are falling in this region. Of course, we can say Lahore is number one and then Indian cities, and second is Chinese, but most of Indian cities are listed there. So we tried to, first thing was that we need to measure the air pollution. So what we did, we prepared the inventory of various pollutant, either it's gaseous or particulate pollution, like PM10, 2.5, and then only you can plan your policy to control that. So this was the first work. And if you look at the PM 2.5 and PM10 concentration, along with volatile organic compound, if I talk about benzene, toluene, xylene, and other low chain organic compound, which are known human carcinogen, they were present in this. And there is a study by our colleague who also showed that there is a kind of a cyanide material which could be also reflected. Another important aspect is that when this crop residue is burned, it is also burning of the pesticide residue which are remain or fertilizer residue which are also introduced to the air, and then you are exposed to their derivative after the chemical reactions. If you look at through high by 1 kilometer, our work could show you that how the air quality look like in this region, and you will see that it is severe to highly polluted during the October, November, and December period. We also try to understand means how this fire count are there, and then their association with the air quality. So you will see that on my left hand side, basically there is a fire count, and this other side you can see the air pollution. So it shows that they are certain belt and pocketed. So it means it is geographically varied depending on the crop and type of agriculture practices prevailing in this region. So this is PM 2.0 emission and PM10 emission during that peak period they look like. Now, if we look at district-wise spatial analysis, you can see means how the pollution is there from burning to different crop residue. And if we talk about means, as I said, our pollution is going to West Bengal. At the same time, the neighborhood countries or areas, basically Pakistani Punjab area, they also contribute. At the same time, last few days back, we saw from Arabic region that there were some storm and they were bringing the dust. So there is also, we can say, long-term transportation of the air pollutant to this region. And when you look at this pollution level, you can see that either it's post-monsoon, winter, pre-monsoon or monsoon, it relatively remain very high. When we talk about this pollution level, you can see the concentration was around 92 microgram per meter cube. So we try to measure, is it only during the crop residue burning? But no, the another activity shows that it is either harvesting, residue burning, sowing or pesticide spray. With
environmental health. Sunila Garg madam है ना? Sunila Garg.
want to ask some question? So these agriculture activities not like we see in urban area, the vehicular activity, their exhaust and non-exhaust, they both contribute to the air pollution. And this is worst, we can say the first study showing that not only these mega city like Delhi, Kolkata, or Mumbai or Hyderabad, but also the small cities, they are paying the cost of air pollution, and the air pollution is even higher in some of these studies, which are like Hisar, Sirsa, Bhatinda, Rohtak. So sometimes we think, oh, air pollution remain a problem of these major cities or mega cities, which have a population of 10 lakh, which has a population of over 1 crore. So, but no, it remain even a problem in small and rural areas. And this is how we monitored using our field campaign data. So we also try to make use of satellite data and then try to understand how this varies. And what we identify were the 4 source: open biomass burning, vehicular, dust. And you will see that their impact or trend, the air pollution level through AOD, because we have AOD data since 2011 to 2023. And when you compare this, basically you can say that rate of change of increase is higher at rural side than an urban side. So that rightly impacting that it is not remain a problem focused on an urban area, but air pollution is introducing or introduced our rural site where we think that they might be clean or they might be means healthier place. So air pollution is becoming a common phenomena. Either it is because of household air pollution, or it is because of crop residue burning or various agriculture activities, or increase you can say vehicular load even in our areas. We also try to look at the trend and impact of policy. So it is like that when you introduce or you come up with a policy, you need to have a sustainable policy. Like in Chandigarh, we saw that when we moved a bus stand outside, when we moved to cleaner fuel, when we switched off the, you can say, diesel three-wheeler, there was an impact. But over a period of time, this impact become negligible, and then the pollution start build up. Like in Delhi, we have seen that when CNG was introduced, there was a decrease in PM 2.5, but later on there was an increase, including there was increase in NO2 and NOx, because the temperature of you can say when the engine start in CNG, because of the higher octane, or you can say higher burning point of CNG, approximately 100 degree, the NO2 or NOx emission increased. So we try to look at this, and surprisingly here you can see the comparison when the air pollution is higher at a rural site, while we think that Chandigarh must be a cleaner, means Chandigarh must be a polluted site. So these kind of impact we can see. Now, what I wanted to highlight here is that this is the rural area which is contributing to pollution. We worked with various, not only satellite, but also this low-cost affordable sensor. We have a NASA citizen science project also. So these sensors were placed at Uttar Pradesh, Haryana, Punjab site, including Delhi, and their results are now under, you can say, process in Nature Scientific. We hope it will be accepted. So when we talk about, is it a problem only in urban area, or how it is linked with our health? So we need to understand that this is not only linked with health, but also with the climate change impact. Because air pollution are also the major, you can say, factor responsible for climate change. You talk about carbon dioxide, or if you talk about PM or other pollutant, actually they are also short-term or long-term climate force are there. So that is why when we talk about it is, you can see if you will reduce air pollution, you will also have improved climatic condition. Another thing is that our life has become so chemical that even in indoor environment, either it is a mat or a perfume or many other things, our house has become a source of pollution. And this sick building syndrome is a common or well-known phenomena leading to because of poor housing condition, which we all studied. But now there is an emerging threat, an emerging pollutant, including during the COVID-19, we were talking about how poor ventilation is leading to spread of the COVID-19 disease. So not only basically these chemical pollutant, but biological, either it's fungal disease or you can say
bacterial disease or viral disease, they can also be a part of because of this. And in this slide, you can see that how these various factor, either it is occupant behavior, air exchange rate, outdoor climate, weather condition, they all lead to impact on the climatic condition. So this is a common phenomena we see, and we consider it's fine. When we go to the village, they also say, yes, it's fine. Our study has shown that people think that there is nothing to air pollution except respiratory disease. But if you look at global burden of disease, which I will be discussing also, based on the global burden of disease data, respiratory ailment only take 23% of the disease burden, whereas cardiovascular and rheumatic heart disease and cancer and other disease, they take basically rest of the burden. So basically more than 70% of disease burden is related to the cardiovascular disease, and we are thinking that air pollution is a problem of lung or eye pollution. So we looked at this, means how the various pollutants are distributed around, and you can see that still in India, 60% population rely on solid biomass fuel use. And there are studies which are also showing that if we minimize this, and that is why where the Prime Minister Ujjwala Yojana is being planned and implementing for the rapid transition. Of course, there were issues, challenges during the COVID-19, but over a period of time, we will be having the clean fuel to our rural population. Because if we have this rural population, we will be having a better health as shown here. It slightly vary from ambient air pollution, means 20% of COPD or 20% of acute respiratory, 27, they could be related to household pollution, whereas 20% of ischemic heart disease and 8% of lung cancer could be attributed to this also. So if you look at the disease burden, probably somewhere the total pollution and out of which air pollution is leading the death. Even when we talk about tobacco, that it is not that, but environmental pollution is the number one. And out of this, if you look at the air pollution, outdoor and indoor, if we talk about, is somewhere at the third, and indoor is at, when I'm talking indoor there, it is household. So if you combine them together, it will be the number one risk factor for our health. I'm talking again, risk factor, remember this. So leading cause of death, disease burden, we can say yes, air pollution is associated with ischemic heart disease, stroke, COPD and other. So if we control, we can really have good results. Now, when we have, I'm talking about this, there was a study conducted by PGI and also various other institutes in Chennai and other Delhi, you know, PAPA, particulate air pollution in Asia. Probably this was the first study which produced the concentration response function for Indian, and there were only selected studies. So now there are over 160 studies. But when we go to the government says there is no data or availability to air pollution or life expectancy. This is somewhere we need to think about, because most of the studies are proving association, but not the which are really establishing the causal effect relationship. When I'm talking about causal effect relationship, so what is that? You need to understand that, like in almost 60 years before, Professor Padma Vasudevan from AMC proved that yes, there is a coal pulmonary disease which is found, normally observed in heavy smoker, and there was no action till date. Since 1998, actually, more emphasis was given. Whereas if you look at the tobacco and other, there is a lot of emphasis. So I must appreciate IPHA for bringing this on the platform that air pollution is a major risk factor to health. And I must appreciate all the panelists here, Dr. Sunila Garg, Dr. Mitra, and Dr. Ghosh for highlighting this very important concern. So if we ignore this, basically, we will definitely be having this burden. So what is the exposure pathway? You know that it is ingestion, inhalation, or skin contact, or skin absorption. And at the same time, like where we work, means occupational exposure could also be there. So duration of exposure, activity pattern means how many hours I remain on the road, or I live around the road, means my morning walk Normally people go for a walk when there is a high pollution level. So these could also affect. And India is the only country where people proudly say that, oh, I live just across the road. And there are studies. There was Professor Bart Broekenreef from Netherlands, who was also my DSC examiner actually. His work from Netherlands has shown that if you live close to the road, you have higher burden of air pollution related disease, including arthritis to various diseases through publication, basically he has proven. So it's like that, do not push or do not really force your family to have a home, try to move away at least 150 meters from roads. And of course, in India, this is the presence of other pollutant sources. So if you look at like Delhi, the CNG may produce some certain, we can say hydroxide, which could affect. So majorly, this prime factor that affect the human health are nature of the pollutant, concentration of the pollution, duration of the exposure, state of the health of the receptor, and age of the receptor. You remember, we talk about there is a disease, epidemiological triad or ecological triad. Then we talk about a spiral wheel, where we say that genetic, environmental, and basically chemical factor, they will lead to the disease burden. And in the center, it was host. But what if you are exposed to air pollution today? So there is another evolutionary wheel model was proposed where the time dimension was also taken. So that explains how the disease progress. So in that model, basically, if you look at, we have source, means emission. Then and from emission, there will be a concentration, there will be exposure, there will be dose, there will be health effect. When I talk about this, we need to remember that gender, age, genetic acquisition, all these will affect, and we will be having the health impact accordingly. Now, I would like to share with you our first study from India, or you can say from rural India. We have shown that air pollution is linked with the excessive mortality. And what we came up with a range of air pollution, basically, if you look at annual estimated causes, the lowest number was 93, whereas upper was 390. And surprisingly, if you go to the health center, you will see that in my left hand side, look at the August, November, October, November, December data, the number of hospital admission are decreasing. So am I talking right, or am I talking something else? How it is relating? Whereas we say that hospital admission increase when the air pollution increase. No, we have to understand, and we have to understand our population. As a community physician, as a public health expert, we need to look at the trend and pattern, because days are short. It's very cold. They might not be going to the means civil hospital. They might be finding the solution, which is where you normally go to the other, you can say, medical professionals, or not exactly medical professional to crack. So this study shows that yes, air pollution is a serious threat even at a rural location. So we have seen that yes, if we look at, yes, air pollution is becoming a major risk factor, not only in outdoor, but also indoor, because we are spending more time in indoor. We make use of this indoor air quality monitoring equipment. And I conducted this study in the rural area of Punjab. What we were able to show this, that when you talk about 25 microgram meter cube of indoor air quality guideline, which is not mandatory, basically, it is just a guideline, means it's not binding. What we noticed that even these are the type of kitchen were there, someone cooking outside, inside, another way, the concentration was higher, significantly higher, what we talk about in these one room setup, and specifically think about window, when you close your window. So this exposure increased a lot. And because of this, basically, the exposure was higher with solid-bodied biofuels and lowest was with LPG fuel. And at the same time, if we look at the risk factor were also higher with this black carbon. So we also calculated the mortality. And we showed that means the black carbon concentration is significantly high. As I said, 25 microgram was the black carbon concentration during the peak hour. So you can think about here in this slide, the concentration is shown, means how much they are exposed to this. Even you can see the tar from the rooftop. So just to imagine. So we developed a very comprehensive, you can say, approach where we analyze the data. using this model, which I am showing. Basically, first thing was that you have PM 2.5, then you measure the black carbon. From black carbon, you try to look at the potentially toxic factor like benzoylpyrene, and then you go for calculate its toxicity from International Agency for Research on Cancer, and then try to calculate what could be the estimated number. You know, before going for public health study, we need to understand the theoretical measurement. And at the same time, I measured or compared it with the population-based cancer registry. You know, there are certain registry which are hospital-based also. So the data was compared, and then we come up with certain number, and this is how the standardized cancer death could be there in India based on the ICMR data. And you can see then the black carbon exposure and excess cancer risk in India. So on an average, we can say that somewhere around 2 cancer could be linked out of 1,000 population to household air pollution, which is matching to various other studies reported globally. Another thing is that we recently got a project from ICMR looking after the PMUI and their association with respiratory disease. And what we looked at, yes, there is an association. Here you are seeing ROC curve. And what you could look at, our model result means we did this kind of modeling using R and MATLAB basically. And what we identified that depending on the housing, depending on the caste, depending on the income, basically you have higher chances of having smoking non-TB women exposed to air pollution risk, means COPD and other. Similarly, that is why we came up with this India's Clean Fuel Program journey, and we are seeing that this is implementing and showing positive result. But until unless the whole village get the benefit of clean fuel, the impact will be not that visible, and hence we need to focus on prioritizing that rural area and rural vulnerable communities get the fuel as soon as possible. Why? Because here you can see the risk factor associated and the benefit related to this. For more detail, actually, you can go through our recent article in Environmental International. So when we talk about women, basically, they are occupationally exposed to household air pollution. So I consider it as an occupational exposure because, you know, in one of our study, we have also shown that when we think that, oh, solid biomass fuel is cheaper, no, it's not cheaper. If you simply calculate it through the cost of one day, means Manerga cost, if they go for collecting the solid biomass fuel and then calculate the loss of earning, so it turned out to be even expensive than the LPG. This result I have not seen elsewhere. So this study was published in Journal of Environmental Management, and through my profile, you can explore. We have shown this also, means how this transition is happening. So through structural changes like policy, subsidy, improved housing, my paper with Professor Kirk Smith has shown that if we have a proper exhaust, up to 40% exposure could be minimized. At the same time, if you look at this slide, the social and contextual, means gender equity, means because who make the decision? It's normally the male who makes. So if we consider it as a responsibility, then the clean fuel could be promoted. And then we need to focus on citizen engagement and awareness. And at the same time, we have to also focus on personal and immediate factor like attitude and awareness, like, you know, that people love the taste of this fuel. So only then we can have this fuel transition, means fuel transition toward the clean fuel. You can also look at this article. And then I also published this Khewal model. I love when I hear about Forner model. So this is the Khewal model, basically highlighting how we can move toward better health and better quality of life through this Khewal model, which highlight on the knowledge transfer, housing, awareness, intervention for the PMUI and other, and willingness to pay, means people are willing to pay if they have, means as per their requirement, small cylinder, big cylinder like this, and the government is coming. So this adaptation will be high when you give them on a trial basis and like this, and then the low emission will be there. And this will definitely improve what we see that poor social justice or vulnerable population which is being affected, and dosary and fuel stacking, and then indoor air pollution issues will be covered. Another thing is that improve household air quality. The government has taken several initiatives, and some of us could also be part of it through Give It Up, and then direct DBTL, basically when the beneficiary is given directly, and PM UI. So it's not that all is negative. When such intervention are there, there is a positive impact. And through Lancet Planetary Health article, it has been shown that yes, air pollution was a risk factor, but when there is a action is taken, there is a positive impact, and the number of associated death and disease, they decrease. So if we work together for clean fuel, and if we work together for better air quality, we could address this sustainable development goal, and our earth will become a better habitable place for coming generation or future generation. So if we talk about not only this, basically the COVID-19 situation has also shown us that we need to focus on green recovery, means where we are going and how we are giving back to our society, that need to be looked at. Because if we work for clean fuel, better air, definitely we work or contribute to all this. And here I also want to show you some of our work. Like we developed this booklet, which was adopted by Government of India. And exactly this is the part of now National Program on Climate Change. So what is there? Basically, it is a ARI surveillance program through each state from district level, so that we build up the evidence. You saw my slide that there was no evidence. Now this today means each state was in our discussion. As I mentioned you, it was a national wide review of National Program on Climate Change and Human Health. And there, if we have this at grassroots level, we will have the better data and could be associated with the air pollution. And another thing was that health sector need to understand their responsibility also. So we prepared a booklet also for a health professional. Either it is a medical professional or a, you can say pharmacist or a nurse or ASA worker. So all contribute and can contribute to create awareness to action to minimize the air pollution, and at the same time building association of the relationship. I hope you know that father of occupational health was Professor or Dr. Ramadeo Barjani. So he said, if someone is coming with the disease pattern, I will ask, where do you work? Similar way, if we try to understand the environmental association, probably we can identify the association with these environmental factor, and they are basically determinant for our health, and then we can really help to improve their quality of life. And as the air pollution is becoming a threat, I hope you are aware of the New York situation at this moment. The air quality emergency is there. So how the health sector should respond to that? So we developed a graded response action plan having the vulnerable population and those who have inlaying disease. So they were also included in this, and they will be means what need to be done by a health facility, and even before when there is a no air pollution episode. So we prepared a kind of a air pollution calendar also. We know that in March, April, there is a high load of pollen, and in October, November in our region. So you need to plan according to your region and then act. And another development which Madam Garg was also mentioning, this air pollution infographic released by Ministry of Environment and Forest. So this pictorial guide basically talk about this air pollution, the health effect, and also have several IC materials. So we are pleased that it was adopted by Government of India and released. Then during the COVID-19, we have seen this, how air pollution was linked, and we created this booklet through Ministry of Environment and Forest. These are the booklet basically which were released on 9th March 2020 to create awareness about COVID-19. And I'm pleased that even before WHO came up with their guideline, means how to talk about COVID-19, it was almost a month before then the WHO. Even I approached to WHO, and probably they then took this idea because they said I wanted them to be a part of it, but they had some limitation, but at the same time, ministry released this, and these were the first document globally available. I'm really appreciate the ministry for taking forward, and then it was translated by WHO and UNICEF in their means you can say language like for Africa, and at the same time it was adopted by Ministry of Education Tunisia in Arabic country, and over 22 international languages this was translated. Our recent work is available also in 22 Indian languages. The international translation is going on. It's Kids for You and Climate Change. We are seeing the impact of the heat wave may not be in the North India at this moment or only for selected days. But if we look at certain coastal zone and central India, this is also impacting. And not only this, basically Southeast Asia is suffering because of the heat wave. So this booklet was developed and released last year in 22 Indian language, and more than 10 states has made an agreement with us. So it's a part of the children curriculum agenda. And as an alternative teaching, you are not forcing them, you are just giving them a media to learn and contribute. Another thing is that each one of us can contribute to reduce our emission. And that is where we highlight under the life. And I'm pleased to inform you that my article in Lancet is published about lifestyle for the environment, means how through behavior change modification we can be a part of the environmental solution. So in few days I will be sharing this means my commentary on life. So please be a part of the solution and not the pollution, and look at all problem as a challenge, because we have a large population to solve. So with limited resources, with limited manpower, we have to identify solution for our population. Let's be a part so that we improve the health of the community we are responsible for. And we need to work with the community. We need to understand their practices, and through their practices we have to identify the solution, because they will be long lasting and easily implementable. With this, once again, I thank the IPHA platform for giving me the opportunity to talk for a while, and I will be happy to take any question, queries or concern. Thank you.
If you have any questions or anything to say or any comments, you may write in the chat box as well, or you can ask directly. I would like to request the audience if they have any comments or any clarifications from Dr. Khaiwal. He is with us today.
It has been really a wonderful talk, Dr. Kaushik. Be a part of the solution, not pollution. That is important.
Hello. 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 Hello.
Yes.
Yes, sir.
Okay. I got disconnected for a little bit. Okay. So thank you for the excellent talk. So shall we call the next speaker, or shall we allow for some discussion now?
We call the
Excuse
next
me?
speaker. Call
Excuse
the next
me?
speaker.
Okay. So I would like to request Professor Ajit Dasgupta from JNU to please continue with his presentation, and we can have a discussion after the session.
Thank you. Let me stop my slide.
They have serious mortality rate.
Well, good evening and thank you very much. Ribhu, one question: how much time should I take?
Sir, I think 20 minutes, 25 minutes will be.
I'll definitely limit it to 20 minutes. Once again, thank you very much. I hope my slides are visible.
Yes, yes.
Yes, it's visible.
Thank you. Thank you.
And you are audible, sir.
Thank you very much. I work with health systems, and we have just a couple of days before officially awarded this Wellcome Trust Heat Adaptation Research project called "What is the Economic and Health Impact of Heat Adaptation in India?" This was a Wellcome Trust call on heat adaptations, 11 grants across the world, just one in India. So we'll be beginning this work. And therefore, at this point, thank you very much for this invitation and opportunity. So to get back to what Professor Sunila Garg started with, the relevance of making health systems climate resilient as we engage with a number of climate related changes. Is the slide moving?
Yes,
Review,
yes.
is the slide moving? Okay.
Yeah, it
Okay,
moved.
thank you. Sometimes it doesn't move.
Yeah.
So just to give a broad overview, how are climate change and health systems connected? So one, as we know, there are a set of direct and indirect threats to health, which contributes to excess mortality on account of various causes across age groups, across some very distinct vulnerabilities. Also, extreme weather patterns indeed contribute to trauma and death. And then changing patterns of vector-borne diseases is also very well known, unexpected outbreaks, and we have been increasingly seeing combination of urbanization and outbreaks, vector-borne disease outbreaks of various kinds. And also, and this actually links to where Dr. Kaival's last slide was, or rather one of the last slides was, which was linking it to SDGs, which is that climate change is a threat multiplier, which we often do not see it like that, due to its influence on other social determinants of health, such as clean air, on which he gave a very illuminating talk, as well as other SDH parameters like safe drinking water, food, shelter, and very importantly, forced migration. And this is an increasingly important area in climate change and health. So how does it link? One, of course, is the inadequate healthcare response. Health systems currently are just not equipped to manage these changing health risks. And the Lancet Countdown found that nearly 2/3 of the global cities are actually seriously compromised in their public health assets or infrastructure. And the health professionals' capacity is also extremely limited. And therefore, overall, the healthcare response remains very inadequate from non-resilient health systems, which actually add to direct damage costs. Also, health systems are part of the problem too. The healthcare sector in itself accounts for nearly 4.5% of global greenhouse gas emissions. And therefore, this is another area in which there is increasing work and increasing recognition that health systems also need to reduce their emissions. And health systems are very complex systems. It's not so easy to tweak or tinker with it. And therefore, these requires concerted plans and actions. This is a conceptual presentation of health risk due to climate change drawn from the IPCC 5th assessment report. It may look a bit small on your screen. This is what the present impacts are in terms of vector-borne diseases, occupational health, mental health and violence, extreme events, etc., including undernutrition. As we enter into this decade of 2030 to 2040, as we move towards 1.5 Celsius increase across the globe, this is the era of committed climate change, where we actually see the increase in these impacts, and then should the adaptation proceed, and there would be various scenarios of adaptation, which is shown in this inset diagram. This is the kind of reduction we can see if there is good adaptation, or it can even exacerbate up to a +4 Celsius scenario in 28 to 2100. Now, in other words, as we move through these decades ahead, the health risks are going to increase or mitigate, depending on how the country is responding to climate change as a whole. But at the same time, the health systems also has its task cut out, or a lot of responsibilities, as India or for the United States move through some of these cycles and scenarios. Can we request the audience to be on mute, please? Okay. Now, to come to the definition of what are sustainable climate resilient health systems, this is the WHO definition. A climate resilient health system is one that is capable to anticipate, respond to, cope with, recover from, and adapt to climate-related shocks and stress, so as to bring sustained improvements in population health despite an unstable climate. Now, this really is the challenge, that the climate is going to remain unstable, but we want to make the health system more responsive and resilient to an unstable climate scenario. And therefore, the healthcare sector, including its supply chain, must deliver care without contributing to climate change or environmental degradation. In other words, health sector can't really add to the problem of climate changes or climate stresses, and that these systems should bring ongoing and sustained healthcare to target populations and protect the health and well-being of future generations, which all of us are collectively committed to. To sort of sum up and then move to the next segment, which are the overarching critical factors. We have governance issues, we have deep social inequities, and particularly in low and middle income contexts like ours, high levels of poverty and labor informality. And this is very crucial when particularly one looks at urban, peri-urban contexts. And as we all know, and we are part of, the health systems are already overwhelmed, and therefore the climate-related issues are really over and above currently overwhelmed health systems. And this is a graphic which connects to the health system building blocks. And in the next graphic, we will see how it expands and links to the climate related challenges. So the conceptual framework for resilience moves as follows. Our main context is the health system, and then we have the climate stresses and climate shocks, which leads to exposure, sensitivity, and adaptive capacity depending on one's vulnerability of individuals, communities, or population groups as they may be organized, maybe in terms of geography and so on. It will have a certain capacity to deal with the climate disturbances and a set of choices and opportunities. And resilience ultimately is a function of decreasing the vulnerability, the larger cross-cutting vulnerabilities, and increasing these capacities and choices and opportunities so that there's a transformative change. Now, that in a sense is the theory, and therefore the task really is to understand how all of this can be made to work. So drawing upon the WHO's overarching considerations in building resilience, the first set is actually to reduce vulnerability. And reducing vulnerability has two dimensions. One, the overall vulnerability is linked to the social determinants of health, a range of structural and cross-cutting issues, and then a set of very specific health systems issues, of which we will see in detail. But these are all areas that SDGs, various SDGs targets and goals are linked to, and therefore these two need to work together in tandem. And this is one for reducing overall vulnerability. Second is of developing capacities. Again, we will see in detail how we develop capacities or what the roadmaps are, and then add long-term perspectives to these, because climate change, as we saw in that graphic, it would move, it is more or less 100 years representative graphics that you saw, and depending on the kind of plus 1.5 to plus 4, where we would really settle down. The long-term perspectives, therefore, will need to focus on decisions which need to be, some of those would be short-term decisions, some would be medium-term, in half to 1 decade, and some would be long-term, which would last over decades. And therefore, health systems will really need to have to build up cases for these various perspectives. In other words, there is not just one plan, but a set of perspective plans, depending on the duration that we are planning for. So the WHO operational framework is across these 10 components. So while the building blocks are these 6 components, which is the inner circle, which is leadership and governance, health workforce, health information systems, medical products, technology, service delivery, financing. We know that, these 6. So when we add another circle of climate resilience to it, The health information systems is then expanded into 3 more components. Information systems on vulnerability, capacity, and adaptation assessment, information systems on integrated risk monitoring and early warning, information systems on health and climate research. So this is how the information system is expanded. The medical products and technologies is really about climate resilient and sustainable technologies and infrastructure. That's how this is represented in this outer circle. Service delivery again is expanded into 3 components. One is management of environmental determinants of health. Second, the climate informed health programs. And third, emergency preparedness and management. Many a times we just think in terms of extreme events, and that's what marked also the COVID response, just as an acute disaster. But actually, just as COVID has shown us, climate change is also a slow disaster and not an acute disaster. That's something to be remembered. The acute part is just one of these slices in this pie. And finally, financing. So climate and health financing is its own area. So component 1, I mean, I will not go into the details, you can read for yourself, is about the leadership and governance, and therefore the political commitment and the leadership issues to build climate resilience, a range of legal, regulatory, and institutional parameters to look at. Second, the guiding principles for capacity building on climate change and health. This is again a very big area. Capacity building at all levels. This in by itself is a fairly daunting task. Not to think of the 10 components. We have begun here, certainly. Both these components we have begun, both at national and some of the state levels, as we shall see. Third, which is component 3, as you saw in that circle, which is now moving into the information systems of steps of vulnerability and adaptation assessments. Professor Kewal showed some of it for the air pollution, in the air pollution context. And similarly, these can be worked out for each of these contexts. And again, all of these are ongoing work. The 4th component is, again, in information systems, the key environmental risks that we monitor. So he showed some of the details of air. Similarly, you have extreme weather events. Currently, many states in India are going through severe heat conditions, particularly in the east and even some of the northeastern states. And then you have seemingly not extreme events, but you can have seasonal allergen loads and occurrences, which should be monitorable data. We may not often monitor them as climate data, but climate and health data, but there are several such parameters which need to be increasingly brought into the information systems, or for that matter, surveillance systems. These often do not qualify as surveillance parameters. As far as building the research dimensions go, setting the research agenda, supporting the research and connecting it to policy, these are essentially where governments and international donors and philanthropies are investing. In India, also led by NCDC and say agencies such as the DST, a lot of research is being funded. ICMR also, a lot of this research is funded, and there's a body of researchers in the country working on various dimensions of it. But the challenge is to connect it to policy so that the research findings on climate change and health are both disseminated and used by policymakers. So also, as you will see, we are in June 2023. As we move on to the next few months, within the G20 also, we just had the 3rd health working group in Hyderabad, which was focused on vaccines, therapeutics, and diagnostics, Hyderabad being the vaccine capital. But as we move into the 4th health working group, we will see a lot of climate change and health issues also being addressed in the G20 platform. and in a bid to synergize global North and global South views and issues on climate change and health in specific. In the next component, it's about adaptation of current infrastructures, technologies, and processes, which is the health sector, health systems pillar of technologies, medicines, etc., and how we promote, how we design and promote new technologies, and building sustainability of health operations by bringing in low environmental impact technologies procured and promoted by the health sector. There's a whole lot of I mean, there are many charts like this where a range of interagency and intersectoral collaboration is involved. Again, you heard some of the examples from air quality, so this is amply demonstrated in the previous talk. And each of these sectors need to find similar areas of collaboration, synergy, and joint action. And these are departments or arms and streams within the health sector, that need to be climate informed. So while the previous one is about other ministries working together with health, this is about the specific divisions within the overall health service system that needs to be climate informed and that needs to adapt or design programs as we go along. And this would actually connect to the next box, which is extreme events. And linked to extreme events also is a range of issues of risk management and risk communication. And finally, to come to climate financing, climate change and health financing mechanisms are still an emerging area, and India still hasn't really taken this on in the seriousness that it entails. These are some of the examples of the global climate funds within which there are health components, but we are yet to move into a climate change and health funding, funds really. So finally, to sum up, this is the WHO summary recommendations of country objectives. So this is a view from the above, as you see. So the first task is to articulate to ministries, states, departments, and the public at large the unique challenges faced by health systems and healthcare facilities. Second, and these are more academic responsibilities, of applying methodology and frameworks for assessing vulnerability and adaptations for health systems. Third, apply approaches for measuring and monitoring the environmental sustainability of health systems and opportunities to green health systems. So if you see the WHO monitoring framework, the WHO climate and health action framework. So for all these 10 components, there are monitoring criteria set out also. Fourth, apply the health equity lens, address health system decarbonization and build climate resilience. And finally, develop an initial plan for specific climate impacts. And to give two examples, this is the draft Karnataka and the draft Kerala state action plans that you can read. These are in considerable detail. These are collaborations both of the central as well as the state governments. This runs into about 150 pages, very detailed draft for Karnataka, and the Kerala one runs into 200 pages plus. Both very fine examples of multisectoral actions as well as multisectoral collaborations. Thank you very much for your patient hearing.
Dr. Mitra, are you there?
Yes, ma'am.
Yeah.
Is there any questions or comments from anyone? You may write in the chat box.
I think it was an excellent presentation by Dr. Das Gupta and showing how through implementation research, basically we can address this climate crisis. So thank you, sir. It was a learning for us also.
And also,
Thank
Dr.
you.
Ravindra, I'll say that you also, went from monitoring from satellite center to cost-effective centers, and also you focused on indoor environment. And plus, you also said that it is not only, the air pollution is linked to, one particular aspect, but, whether we talk of cancers, NCDs or COPDs and all that, that is where it is important part of it. And also you mentioned about, that health impact is determined not only by, pollution, but your proximity to where you are staying or your occupation and all. So that is where, all these factors become very, very important part. And I really liked your genesis of clean fuel journey also. So that provided us a lot of comments. And as far as, when I was listening to Dr. Rajiv Das Gupta, he completely had a 360-degree approach with regard to health system strengthening. And with regard to, health systems, also need to cut down the emission. That is one thing which is very, very important. And, if we are increasing by 1.5 degree is increase centigrade of increase in temperature versus 4 degrees increase in temperature. This is where he showed, exactly how the vulnerability increases. So overall, the whole message is that we need to, strengthen our systems at all levels. He gave examples of 2 states, but I feel that it is very, very important, to look at micro level also when we are looking at all the components. That is very, very important, and governments need to focus upon, right from leadership, governance and all that you mentioned about the supplies and all. I feel that each component is very, very important, and at each point of time we need to have, specific indicators to meet that. So thank you, Dr. Rajiv, also for both the presentations, Dr. Kewal, and they have been really excellent. But whatever are the questions, we can take up the questions from the chat box. If there's any. Somebody shared that they have a data on cardiovascular diseases also. And then there is one, Dhruv has said, can you share the link of the draft you showed? That is to Rajiv. That is there. I think there are no specific questions if I can see. Can you make out any, Dr. Mitra?
No, there are no specific questions right now.
Any data regarding air quality change during lockdown? Dr. Kewal, will you be able to answer this? During lockdown, did we have any? Rather, I think if I could make out across, overall, barring the lockdown period, you said that rural areas, urban areas, or when we talk of cities and all that, pollution is across everywhere. But then this is a specific question during lockdown.
Thank you, ma'am. It's a very good question. Basically, if you Google only Ravindra Kewal, you will see that we published in Environmental Pollution how making use of 134 continuous air quality monitoring station, how the air pollution varied at various geographic locations during the COVID-19. At the same time, in Environmental International, there is a study by Sokhi et al. Where we provided the data from India, which shows that how the air pollution varied globally during the COVID-19. So I will strongly recommend these to study, and we'll try to share the link through chat box. So what we found out, basically a new baseline in, you can say, what is the outcome of this during the COVID, basically, which was in March end, or you can say April. But normally such baseline are observed during the monsoon period otherwise. Thank you.
Recording in progress.
Any other questions?
As far as these documents are concerned, I can certainly share it with the IPHA, and it can be posted wherever this is.
You can put it on our IPHA WhatsApp group, so we can.
I'll email it and then it can be put out.
Yeah,
in a
sure,
suitable
sure. That
platform.
will be better,
Thank you.
yeah.
I think there are no other questions. Yes, there is a question from Dr. Mayur Reddy. Is there any stubble burning issue in South India like you see in North India? To Dr. Ravindra.
Oh, very important question. Sir, actually, if we look at the data, yes, it is there, but because of the already baseline is low, so these are remain neglected. Otherwise, if you look at the crop residue burning is not only a phenomena of North or South, it is a global phenomena. And that is why there is a concept of prescribed burning, means basically as you cannot get rid of it, so you decide the day based on the meteorological conditions, so it minimizes the pollution level. So on a particular day, and when you know that tomorrow is going to be rain, so you can ask to burn. This is known as prescribed burning. These are some of the solution also. Another interesting thing I would like to highlight is that our paper just published showing that it is not only that October, November, the air pollution remain high during the April when there is a wheat residue burning. But during that time, the atmospheric boundary layer is so high that pollution mixing become a common phenomena, and the pollution level remain lower than the winter if we compare. But the pollution from the crop residue or agriculture activity remain high.
Okay. There is another comment from Dr. Mayur. Any recommendations to government to observe single day lockdown at least a week as was recommended by few nations? To Dr. Ravindra.
Okay. What we have learned from the COVID-19 is that lockdown is not effective. What is more effective is that instead of a lockdown, we adopt life, and not for a single day, but for 365 days. So let us look at this life approach, means lifestyle for the environment. I understand that industrial emission, their contribution is the highest, but when we will become conscious, we will be also buying product from the company who are making use of non-fossil fuel product or sustainable approaches in their produce. Definitely, it will lead to a major impact, and the industry will also be forced to minimize their emission. So only through life, which was introduced by our respected Prime Minister initiative, we can contribute as an individual, as a society, and as part of comprehensive structure where industries, corporation, and all can contribute. Thank you.
Thank you, sir. We do not have any other comments or questions here. So I would like to thank both the speakers. Oh, there is another question, I think so. Hello, from Dr. Anuj. Just a minute. Anuj Rajiv Bhai Dave. Hello, sir and madam. I just want to add regarding the air quality data before lockdown and during lockdown, which was published by ICMR. There is also a study regarding the same. You can check that out if you want. It's a comment from Anuj Rajiv Bhai Dave. Thank you, sir, for your comment. If you want to tell something also, you're welcome. Otherwise, I would like to thank both the speakers, Dr. Ravindra and Dr. Rajiv Dasgupta, sir, for your excellent presentations today. We are honored to have with both of you here in this platform. I'd also like to extend my thanks to our President, ma'am, Dr. Shanghomitra Ghosh, whose enthusiasm has brought this into life. And along with her, we have Dr. Professor Sunila Garg, ma'am, our chairperson of Indian Academy of Public Health, who is behind the scene in all these day observations and master classes. And you, the audience, without whom this would have been incomplete. And I would also like the audience and our members to write to us regarding any master class, any lecture, or any day observations which would like to have from us or any other CME at iphhq@gmail.com. All your suggestions will be welcome. Thank you all. Thank you, sir. Thank you, madam. I'd like to close the session.
Thank you all, and we are grateful to IPHA for such an opportunity, and we look forward to contribute more.
Thank you, sir. Thank you.
Thank you.
Namaskar, ma'am. Namaskar, sir.
Namaskar. Namaskar.
And Dr. Das Gupta, I will meet you soon. You are in Delhi.